Brilliant. So shall I just crack on?
Yeah, no problem at all.
Yeah, excellent. So yeah, quick introduction. My name's David Hopper. I'm one of the physiotherapists within the JMAPS Northumberland service. I've got sort of a long history working in pain management, where I think it was about 2010 I started working in the medical pain service. So I'm one of those people who unfortunately advise people to take ketamine and fentanyl and all those other nasty medications that we no longer prescribe. So I've got quite a good overview of the medical side. I also work in something called the CAT service, which is more the sort of the combined assessment and treatment service within JMAPS. So got a pain and a musculoskeletal diagnostic slant in the pot. So really what I wanted to do today is just give a bit of an overview of the Living Well with Pain service. There's been a bit of change, and then I think that change mainly started around 2019, and then COVID struck. So I just want to go through that a little bit more. So next slide, please. Well, so just a bit of the brief history, as I alluded to there, is basically the Living Well with Pain service sort of came about due to a number of discussions, more so around the spinal pathway, which was around in 2018 and 19, where there's concerns around the amount of prescribing there was, sort of high level of opioids, gabapentinoids. We were quite outliers with regards to number of injections for spinal pathology, which wasn't 100% indicated from the evidence. So there was a lot of talks around how we start to redeem some of these problems. And one of the solutions was really to start to reduce the medical input into the pain management service as it was, and start to develop more the MDT aspect, which was the greater evidence aspect of the service. So let's say around the 2019 mark, the two did separate. The physiotherapists, psychologists, nurses became the Living Well with Pain service, and the medical model became the medical pain service, which still exists in some guys. There's Dr. Coe and Dr. Bamigbadi who still work within Northumberland, leading the medical aspect, and they continue to see people for specific injections, a lot around the medial branch blocks, RFAs. Also now Newcastle don't accept spinal cord stimulator referrals from physiotherapists, so it has to be from a consultant referral. So they're still linked in with that aspect, as well as dealing with that cohort of people who still sit on the high level of complex opioids, the ketamines. There are still some people on nabilone kicking around as well, so they seem to manage that side of things, but we don't have that definitive link with that service at the moment. We try to meet up with them at least once a month, purely because there is still the links between the VBCs required for medial branch blocks and that link between MDT rehab as well as injection. So we still have a little bit of a link, but it's not as combined as it initially was. And that's a very similar model in North Tyneside. But where I think the difference in North Tyneside is the Living Well with Pain service is the access route to the consultants, whereas in Northumberland we're totally separate, just for reference. And next slide, please. So really the role of our service is to empower patients to manage their persistent conditions. So what we're trying to do is give people the tools to cope with these things longer term. Obviously, in any long-term condition, there isn't a definitive endpoint. There's not that have that operation, have that cure. So we need to make sure that these people have that confidence to move things forward independently. A lot of the time we try and demedicalise approaches to persistent pain, which is difficult sometimes when you're switching your hat from a CAT service to a pain clinic in the afternoon. It's a very different mindset, but we try and sort of advise and guide and educate to try and break some of those sort of hard, fast thoughts that patients have that are sort of blocking them from moving forward. I often talk about it's a bit like a journey on a bus. They're stuck at the bus stop waiting for their investigations or tests, but they're actually not moving forward in life. So what we're trying to do is get that rolling again. Reduce medication requirements, sorry, and that's a tricky one because we do get a lot of referrals saying we're taking people off these drugs. Can you do something to them to help their pain? That's a challenging question because that's the the thought that the patient has that we're going to come and take away their pain because somebody's taken away their pain medication. That's not our role. But what we hope is when they have improved quality of life, management structures, better coping, that they won't have that reliance on medication. So indirectly, that will reduce. So it's a bit egg, chicken, chicken, egg. So rather than getting rid of their pain to reduce the medication, they're trying to improve their quality of life in order for them to reduce their medicines. We're looking at optimizing them. I use that word a lot, is that, optimizing their potential. That with a lot of these people, there are things wrong with them. We've got to be realistic, but what we're doing is challenging all the bits that can be improved. I'm a great cyclist, and it's like the Sky Cycling Team marginal gains approach. What we're looking to do is improving anything we can improve to improve that quality of life and that overall experience. And that's where we'll come to a bit on the referral forms on why we do that, but also tools to provide a valued approach to living. And this is the big bit. We talk about values a lot, but that's the patient moving forward with a quality of life that's important to them. Often sort of people have quite big lives, and then pain comes along and it goes really small. All the bits they enjoy that are positive to them get lost, and you're left with housework, work, and all this stuff that doesn't really hit off your endorphins a lot, and the quality of life deteriorates. So what we're trying to do is to really give them the tools to sort of move forward with that aspect. Okay, next slide, please. So I also like to flag what we can't provide, because there is a lot of misconceptions out there, and unfortunately we do bounce referrals and from triage as well. But really the crux of what we can't provide is a cure or focus on pain reduction. So as I said sort of before, is we hope there's an improvement in pain by using all these strategies, but the focus is really improving quality of life. And I often have that conversation with people when I see them first time round, is that I'm not here to get rid of your pain. I can't promise your pain will reduce, but what I can say is that hopefully you'll be able to walk further, you'll be able to do more, you'll be able to enjoy time with your family. So the effect of that pain and that pain experience is going to be less loaded on you, and in turn quality of life will improve. And I think that's difficult, and that comes down to patient expectations of what they think they're going to gain from the service. And a lot of people don't think it's been effective because they'll go, well, my pain's still there, so it hasn't worked. And what I'm trying to say is, well, if you change your focus to your pain's still there, but now you can go to the shops and do your shopping, it has improved. Your life has improved, and that's what our focus is. And we spend a lot of time setting that realistic expectation at the beginning. We can't provide injections. That's not something we definitively do. So if a referral comes in, this person requires medial branch blocks, we would reject that, unfortunately. I think the referral pathway within our areas, that would either go through orthopedics or direct referral to the pain consultants, as long as they've done the multidisciplinary team build-up. We do get referrals from Chris Coe, Mr. Cassis, Mr. Jensen, saying, please can you provide multidisciplinary rehab for this person so we can inject them. That's not the best way of pushing our service, unfortunately, but sometimes that's just the process that people have to go through. And quite often, once you've done that rehab with them, they decide against the injection. It's actually I'm coping okay. I don't feel I want to go through that for something that's not going to have any great longevity. But we don't directly provide the injections within our service. Neither do we provide medicine management. And again, we get quite a few referrals on, please can you look at this person's medicines? That's not something we provide, and it was agreed right at the beginning that in general practice would hold the control over medicines. Obviously, there are some complex medication reviews. Obviously, there's advice and guidance and referral onto the pain consultants who can do that if required. And this is where there's a slight difference with North Tyneside, and that's been some of the confusion on some of the referral forms, that they do have pharmacy time. I think it's 3 sessions a week with a pharmacist who works into our team in the North Tyneside catchment, looking at sort of opioid reduction and gabapentinoid reduction, and just a bit of support with that whilst the person's within our service. So we're trying to sort of combine and do that real multidisciplinary approach to that medicine management, rather than, they turn up to pharmacy and their morphine's been halved and they have a bit of a moment. But that is, I think, something that has been muted around trying to bring into Northumberland as well. When we say assessment of new presenting conditions, that's partly put in is because one of our sort of remits for triage, that something's been fully investigated and we know there's no answer or definitive intervention that will be positive for the patient. So that's why we put that in. And also, a patient may access the service and never see anybody to assess them. So if they go from triage to psychology to discharge, they may go through and not have a medical examination. So that's something to be sort of mindful of. They don't all get assessed. So it's just being a bit aware of that. And finally, I've just put on there psychological support for non-pain related mental health problems. That's a biggie. You know, mental health services are hugely stretched across the board and in the community. And what we're looking for is that we don't provide mental health support for sort of background mental health problems. We try to support mental health in relation to the pain. So people have pain, then that affects their mood. If they've previously been slightly bipolar and manic or marked depression, suicidal, pre-pain, that's not something we tend to deal with. There is cases where things like conditions like such as fibromyalgia, which is a prime one, which usually has a background of trauma. We do some trauma work with them because that is a predisposing factor to their pain conditions. But it's trying to find that balance. And I always think psychological issues are a very grey area, but we try to focus on supporting people where their pain is having a direct effect on their mental health, rather than the mental health being the main crux of the issue. I can ask questions on that later. I know it's a bit confusing. So next slide, please. So I said the team at the moment, we're looking at building, but it's mainly physiotherapists and psychologists. And it's a bit like a Venn diagram. You can't separate body and mind. So, you know, same with our therapies, there is quite a bit of crossover. And when I say psychologically informed physiotherapy, what we're talking about is focus on value-based goals, sort of rehabilitation towards quality of life, more so than I'm going to click this joint and you're going to be better. Which would be lovely if we could do, but unfortunately, most of the time we can't. We do a lot on activity management, exercise by prescription, and generally a lot of people who persist in pain are terrified of activity and the reaction of their pain afterwards. So we talk around pain education, getting them understanding what is going on, reduce that fear, that threat, and also try and improve their functional capabilities, because that is one of the key things in improving well-being and quality of life. And as well, we spend a lot of time trying to break that it's all in your head concept. And, you know, as soon as you mention psychologists, people go, oh, you know, you think I'm making it up? And it's like, no, that's not quite the case. We do spend a lot of time, if the patient wants, talking around how pain works, you know, the concepts of that and why, and relating that to the concepts that we use. And it is a challenging one, but I say it's just trying to break down some of those concerns, worries, and barriers. And from a psychological viewpoint, our psychologists tend not to work on one specific model. They'll pick and choose between the clients that they see. So whether that's acceptance commitment therapy, cognitive behavioral therapy, eye movement disassociation restoration, compassion focused therapy. You know, what they do is they pick and choose with regards to the patient that's in front of them and try and focus on that. Usually with the trauma ones, it's more around the EMDR side of things, but they're a much more comprehensive input that they'll require. And also the lesser level things like mindfulness, relaxation approaches. And we're trying to employ some psychological practitioners to sort of help with more that lower grade intervention as well. Next slide, please. And other services we do a number of groups. So we have sort of low intensity education groups, which are really about 3 sessions, which follow something called the 10 Footsteps, which is a tool produced by the Live Well with Pain service on providing sort of not a diluted, but a more condensed approach to managing long-term pain. So people with less intensity of pain issues do tend to respond quite well to that. We run walking groups and gym groups, really looking at a bit of socializing, a bit of confidence, you know, from a functional viewpoint, compassion focused therapy groups, the more structured pain management programs, and also linking in with more and more with the social prescribers. who are a fantastic resource out in the community for sort of putting these people into smaller groups. A great example is sort of the men in sheds groups. Isolation is a big thing with persistent pain, and getting these people socializing again, and also support in things like financial worries, benefits, claims, housing. All these things drive into the pain system. They're great support in those areas. Next slide, please. So referral into the service, what's needed? I've underlined patient engagement. That's a big thing, and it's a really difficult one to build. What we hope, the ideal world is that these people present a number of times in general practice. The same within the musculoskeletal services, and if they're seeing the same person, getting the same advice over and over again, that you start to turn their thought processes slightly, but that doesn't tend to work in principle. They'll see various people, different ideas. But what we're trying to do is get to a point where the patient's willing to look at trying something different. That they're not using this as a route to another investigation or another test or a hope for cure. And often there's always that acceptance. Yes, I'm fine. It's just to get in another stream where somebody might do something to them that will cure them. We want them to know what the ethos of the service is, and there's some resources on the Northumbria website with regards to Living Well with Pain service that they can have a read through. That's on there. And also the new referral form, which I'll come to, has got a bit of information on that. Screening for sinister pathology. Again, it's purely because these people might not get assessed by somebody who's medically educated background from that sort of pathology point of view. So if you see a psychologist, they do struggle to ask around the red flag questions or concerning questions. And that mental health won't affect engagement. More so the fact that if somebody's grossly anxious and won't leave a house, it's very difficult to build up a valued approach. So we'd hope they're more managed in the community, as well as not really high risk to self-harm. We do get clients through who are very high risk, and they are screened out and guided back to the crisis service. But just to be mindful, that's something that we tend not to hold within our team, just because it's a bit harder to keep an eye on that client group. Next slide, please. So what we require from yourselves in primary care is the clinical referral checklist form, and that just really goes through the red flags, mental health, and that discussions have been had with a patient that they are interested and keen to try something new, that they want to move forward on that bus, they don't want to stay at the bus stop, and that they have got I say acceptance, that they're not fully accepting, but as I say, they are willing to look at a bit of a change. Okay, next slide, please. The patient form, this is something that's come in a bit more recently. There's been quite a lot of confusion on what to fill in, what not to fill in. But the patient form is new but really valuable to us, and that really starts to flag patients' expectations and goals, not just what the referrer wants. Obviously sometimes what we think's best for the patient is not what the patient wants, but this gives us a clearer picture of what the patients actually wanted to engage in. It makes them think about what they're opting into. It also flags risks, concerns. Another positive thing, it allows single clinician triage. What we used to do within the service is assess people with a physio and a psychologist. But what we're now doing is using the triage forms to do single clinician assessments, apart from the really complex ones where we do joint assessments, but just allows us to get a really good picture of the patient before they actually turn up, and give a good idea of their physical and emotional levels pre-assessment. Next slide, please. Just pop these in. This is what it looks like. So on the left, I know I don't expect you to read this. It's exceptionally small on my screen. But the first bit's a little bit about education around what we're looking at. A very brief bit of education. I know it's very difficult to get people to read anything, but it just gives us a little bit of info. And the rest of it really talks about what the patient's expectations are. And that's fine. If you go on the next one, Michael, that'd be great. The DAS one, next slide. That's it. So, and a couple of psychological questionnaires, and these are really what we're using to triage out the really high levels of distress, high level of risk patients, where we would probably triage them directly off to the psychology, or return to refer saying, I think this person needs sort of a bit more of a community-based support. Just to flag at this point, obviously there's been new forms sent out, and they're all in little bits. So what we're doing is compiling a single document that can be given to the patient, which is editable. And also with my colleagues in Connect Healthcare, we're trying to look at an editable form that can be just emailed out or AccuRx'd out and returned to save patients bringing back bits of paper, because I know it's a real faff. But within the next week or so, we're going to try and get a more singular document sent out that'll be much easier to give to patients and for them to return. Okay, but the problem is we need both for to triage. So we need the clinical form and the patient form to do the triage. Next slide, please. So as I say, the referral forms allow us to build up the picture of what the patient's expectations are, and that allows us to stream into whether their demands are more of that of a psychological basis or a physiotherapy physical basis. That the patient does have the choice to choose what they would like to do, but what we do is use the triage criteria to actually guide on where we think they're going to be best placed. Okay, and next slide, please. So I'm getting through it. I know time's pressing. So really our aims are to shift that conversation away from the medical model and really dealing with the whole person. I really like the iceberg picture there. You know, I often talk to people is, yes, you do have physical problems. You know, that's the bit you see above the water, but what we're trying to deal with is other things that contribute to your deterioration and quality of life, you know, whether it's sleep, money, medication, worry, lack of fitness, all that. And we're trying to look at maybe it's a bit more under the water than what we see on the surface with the patient, and really looking at to support and guide the people in a meaning, valued and fulfilling life despite their pain symptoms. And I think that's, I often say it's a bit like Ronseal, you know, the service does what it says on the tin. It's live well with pain. It's not the getting rid of pain to live well service. And that's the way I reflect on it. And last slide, just for your information. These are a couple of really good resources. I'm sure most of you are aware of them, but the Live Well with Pain website has got loads of really good resources. There's something called the 10 Footsteps as well that you can do online, which is something we often guide to the lower distress level clients, and as well as Flipping Pain, which is a great resource. Nick at Connect is involved in that, and there's a lot of education seminars around persistent pain. There's a chap called Laura Mosley who's really high up in pain education and pain management in persistent conditions. Great resource that patients can access independently, and it could be just a link that you ping out on AccuRx just for people to have a look at before they come back, before deciding to opt into the service. Okay, sorry, I've run a bit on time there.
Not at all, David. That was great. Thank you very much. We started a little bit late, so I don't maybe have an extra 5 minutes. There's no questions coming to the chat, but knowing virtually everybody on this call, I can't believe there won't be any questions. So I just would like to open it up. If anyone, oh, there we are, Dr. Waite. That's a good start. I knew it would be you, Chris.
Hang on, is my microphone off?
Yeah, good there now.
Yeah.
Really practical, but that was a really good, really helpful, and you're providing just what we need. And I think it's really useful that that where you're coming from, it's helping these people that are troubled by pain, living with it, and it's important as us as clinicians not to give unfulfillable expectations of your service. So that's brilliant. It's a practical issue, actually. One thing that I'm not clear on is how what the practicalities of the questionnaire that the patient gets, how that gets to them, and how that then gets from them to your service. What's the mechanism of that?
And this is something we've been looking at because it varies between different practices. What historically used to happen is that you would fill out the clinical assessment form, and that would be held on, say, System 1. The paper copy would be given to the patient. They fill it in, bring it back to the practice, and then that's scanned across to us with the clinical checklist as a wanna, and we triage it at that. What we're trying to do, as I say, is get a Word document put together that you could do the clinical form, AccuRx the questionnaire to the patient sends that back to the practice, and then the whole lot's sent off at that point. But at the moment, it's whether you able to print that off, give it to the patient, and for them to bring it back. Because the concern is sometimes if they're trying to do it all in clinic, one, you haven't got enough time to do it. I'm well aware of that, but also they don't take the time to think about it. So I don't think there's any problem with if they take that questionnaire away to fill in, and if they're okay to bring it back for that to be scanned and sent back. Does that work at a practice point or not? No.
I guess one of the challenges with it is that's got a time cost and a bureaucratic cost at the practice that can make things go wrong as well. I can see the importance of it, and I am definitely keen on trying to get rid of the paper. Yeah, for us, that's really difficult to administer, and you know, we're trying to keep our costs down, and particularly labour costs, and that's got that cost for that referral, which could also be a barrier to referral.
Right. If it was done by something electronically that we can send out and then send it back to the practice, is that the same issue?
No, it would be less of an issue. So we wouldn't have the printing costs, the paper costs, the cost of contacting the patient to get them to come back and pick it up, and then the cost of them coming back, interrupting the receptionist, then that going off. So it would have a cost, but it'd be much less than the cost of it happening on paper. So yeah, that's why I'm quite keen, because we want to help you as much in the service, but by the same token, bureaucratically, we're on our knees.
Yeah. So I say, I mean, Nick maybe able to help me a bit with this, but for Connector, looking at trying to create a sort of like a Microsoft Forms version of that could be AccuraRx sent out and then returned to the practice once they fill that in, and whether that process might work a bit more efficiently. Yeah,
that does sound much better. Of course, my preference would be for it to be entirely handled by Connect, but certainly the practice handling e-forms would be much easier than the practice handling paper.
Right. Okay.
So we'll go to Chandra first, and then Jonathan after that.
Hi. Yeah, my question is, would you still see the patients who are sort of quite entrenched in their pain with a lot of particularly opioid prescribing?
Yeah, yes, definitely. But again, it comes down to patient expectations. So if the patient is saying, you know, I have a lot of pain, I'm on a lot of opioids, but actually I'm ready to try and do a little bit more, that there's got that think in the armor that we think we can get in there to sort of start moving them forward from a quality of life, that's absolutely fine. And you know, I hold my hand up as being one of those people who have put those poor patients in that position by prescribing advising a lot of opioids in the past. And I think there's an element of a responsibility that some people do get on a lot of medication through no fault of their own, in which case, yes, we can support them as long as you feel happy that they're not abusing or using it as a positive gain.
It's often that it's not working, you know, they're on and it's not working. And we do have the odd patient who say, I want to take less medication. Okay.
And I think that's the way you phrase it is, you know, what the service will do is trying to look at improving what you can do, how you can do it, improving your quality of life. And that means that, you know, that taps into your own natural endorphins, your own natural well-being chemicals. And if you reduce the impact of pain in that manner, you might not need as much. But what we struggle with is we're sending you to the Living Well with Pain service so you can reduce your medication. It just has a little bit of a different slant on it, and that's an expectation that, you know, we have to look at.
Thank you.
So well managed, Jonathan. Just go. Yeah,
that's fine. Nice to see you again, Dave.
Hi, Jonathan.
I thought that was a really good presentation. A lot of things that you were saying that I say to patients, if you know what I mean. But it's, do you know what I mean, that 10-minute however often thing, and they're still on lots of medication. There was a few things, I mean loads of things. I think that if there was the integrated medication management, that would be massive, if you know what I mean, like there is in North Tyneside. I think that would be really helpful, because not that that's the aim of it, but it would be really helpful if that was one of the outcomes of it. Do you know what I mean? If that was required, if you know what I mean, or if that would be helpful for the patient. So I think for the future, that would be really good. I presume the reason that this couldn't be self-referral is for you need to make sure that that they've been screened for do you know what I mean? More worrying things.
Yeah.
But could it not be a permission thing where you say, I think you should self-refer to this, and then they could self-refer?
And I think you sort of do that in a way, you know, with the referral form in a way, because that they won't get, you know, it's fill this in and bring it back if you want to access this.
Yeah, no,
so it's like an opt-in rather
that,
than self-referral.
But it's a bit like NRP in terms of you give people the option to refer and whether they do it or not. But as Chris was saying, that's then coming back to us to re-administer to send on. Whereas if we go, here's the link, and then they refer themselves to you.
Yeah, I mean, in a way, because we still accept people through JMAPS, which is self-referral. So our physiotherapists do also have access to Living Well with Pain. So it might be if they spoke to somebody over what we call PhysioLine, they could give the patient a link to the Living Well with Pain service. The patient could have a look at that and opt in that way if they wished. So in a way, we do have a self-referral route, but just with a couple of caveats to make sure we've screened the nasties.
Sorry, this is slightly off topic, but it's, what do I say to people who say, I've done physio, or you're saying it's all in my head? Like, do you know what I mean? How should I be selling that to people? Because I'm sold. It's just what the things that catch people's imagination are.
I think it's more that the physio's not going to be looking at getting rid of your pain. We know there's not an answer to that. The physio's there to help support you to be able to do more. I quite like the bus analogy of the fact that, you know, at the moment we're stuck at the bus stop, life's moving by, but your bus isn't moving. The idea of that team is to try and see if you can get on that road. You know, at the moment, you're not going out, you're not doing things with your children, you feel like a bad husband. You know, what they're trying to do is optimize what you can do. You know, despite your pain symptoms, your muscles do work. You could get stronger. We can improve your sleep. We can look at all those, you know, like the iceberg thing. I often think is quite a good one. You know, we've got your physical bit on the top, which we're really struggling with managing. But actually, if we improve some of these things underneath, maybe quality of life might improve, and any improvement's better than how you are at the moment.
And generally, under nearly all circumstances, I'm saying to people, move rather than don't move.
Yeah,
if you know what I mean. And like, as in, that's it, because a lot of people, as you say, the fear thing is, it's painful, I shouldn't move because my body's telling me not to move. And I think it's changing that mindset round, isn't it?
Yeah, and that's where there's some quite nice, again, it's trying to lead a horse to water. That on those links, those websites, there's quite a lot around how pain works. But you know, you could say the physio and the Living Well with Pain team will talk to you about this and talk about how it's not causing damage. It's very difficult to get this over in 10 minutes, and I don't want to poo-poo it and dilute it, but they'll have some time to talk through a little bit more and hopefully reassure you.
Brilliant, thank you.
Thanks for that. I was going to say there's something coming in from Nick, so thanks for sharing that one, Nick, as well. David, thank you so much for taking the time to come and speak today. It's been really, really useful. Is it okay if I share the slides out with back to the participants? And
yeah, absolutely. And again, you know, any questions accessible through Connect or through the Northumbria system. Graham's got my email, so he can always put it through.
Well, actually, I might even share your email as well. And,
yeah, that's absolutely fine. And I think it's difficult because it is so new and there's little things changing, and COVID came in and messed everything up. So sort of information streams broke down. So, you know, please feel free to email if there's any queries.